yourself, Jacob. Um, so whenever you're ready.
Um, so I guess what's simple is my name is Jacob Templer. Um, I'm a physical therapist. I have my doctorate in physical therapy from Utica College. I also have my certification in mechanical diagnosis and therapy. Um, I work in Rochester, New York, at a practice called Physical Therapy Services of Rochester, and then I do the injury management for the strength guys.
Nice, cool, yeah. So when you kind of we were going back and forth, and obviously we have a strength guys chat, and we talk a lot. But I did not think, um, or I'd never really seen the pain neuroscience field very much. Like I had so my PhD's in neuro or sorry, rehab science, kind of familiar with it, but not super familiar. Is there any reason that you specifically picked this study, or like, is there anything you want to kind of set it up of, you know, this is important because of, you know, whatever you think?
Um, So I always kind of like stuff on neuroscience education because of the effect it can have on somebody without necessarily having them do exercise or things like that. Adrian Lowe is usually pretty good about practical application of research too, um, like presenting it in a way that you can actually go then use it with somebody versus
Hmm.
some most studies tend to be a little bit more abstract and harder to like extrapolate the information to your like population and immediately use. Um, and then I thought this was good because he used a lot of measures in it that are useful for trying to like group people that may be at risk of development of chronic issues. Um, and then it would give you a foundation of like some types of education to give somebody in the one where they were like in the low group, they're not at a high risk for developing chronic pain, but like to try and prevent that, reduce their services needed. And then it looked like like the people in this study also were um like they were like kind of on the fringes of like could be at risk of development of chronic issues.
Yeah, yeah. So I mean, I thought it was pretty interesting, mainly because like the practical application of, you talk to someone for 15 minutes and that's kind of your intervention. So I'll just kind of briefly describe the design of the study for the audience. But so it's a basic pain neuroscience education session, which I assume simulates kind of the time you may have with the patient, and it was done on non-chronic lower back pain patients who were kind of in the first 3 months, and so that's where you mentioned they could be at risk. So these are what I interpreted as at risk people.
Mm.
Um, and so basically what they did was they did some tests, they gave the intervention, and then they redid the tests. And they're just trying to see if it made a difference. So is that kind of the overall design of the study, would you say?
Yeah. Yep. And one of the things to note is that because typically, like for chronic pain, for back pain, it's described as being 4 months or more. And then one of the outcome tools they use is called the Start Back Nine, like I had said, and that's been used a lot heavily to stratify people into some of these groups that like you're at low risk, so they should get just some education reassurance and don't need like physical therapy or chiropractic.
Hmm.
DM group is usually one that you're going to send to physical therapist, a chiropractor, and manage with a physician. And then a high risk group is somebody who typically um, is going to be seen in a rehab setting, but also may get a referral for like a social worker or psychologist because they have certain um, psychological risk factors that need to be addressed with a specialty service.
Yeah, yeah. And I thought it was neat that um, it's not big, so it's like 80 people or something,
Yeah.
which is pretty powerful. Now, it was a single arm study, so they didn't have like a control group or anything, which um, is kind of annoying. But I think with this type of intervention, it seemed like they're just trying for feasibility. Like, is
Mm-hmm.
this a thing that might work? So they recruited from the area where they're located, it seems like, through orthopedic physical therapy residents and things like that, which in the kind of clinical trial world, that's also very typical. It's like, oh, I'm doing a knee and hip replacement intervention. Let me go over to the orthopedic surgeons and ask for patients to recruit into my study. Um, so we had a study where we like recruited those people and then put them on different exercise regimens.
Mm-hmm.
So that's the recruitment of the subjects isn't that abnormal, but I thought it was pretty cool. It's a big sample size,
Yeah,
and
and
so when we talk about good,
well, the fact that they got it from 7 different centers instead of just a couple centers.
yeah, that's true. Because I mean, at least in my world, um, you'll see the same type of people go to the same centers. Maybe that's location based, or maybe it's economic based, but that's actually a good point that they pulled from what seems to be everywhere. So let's.
Yeah, because
So yeah.
well, I was gonna add on top of like because the 7 different centers. So like when I worked in Syracuse at my last job, we had the clinic, the place I worked, we had 5 different clinics, and so like you could even see the difference between like a city like that. I think there's like 150,000 people there, and even in Rochester where I'm at, there's like definitely different demographics depending on where you are in a city like that, and in different socioeconomic levels and like all the different sections of the city.
Yeah, yeah, for sure. Um, okay, so let's get to kind of your background and training. So, if is this something that you guys get trained on as physical therapists, or would this be like an additional education type thing? Because it seems like they had the people who were doing the intervention, they trained them for a couple days, and they're like, all right, you're kind of good to go now.
Yeah. So the thing is that majority of the time in school, you may be trained on pain, but not as much. Like you're gonna learn the neurophysiology, neuroanatomy, and stuff like that. But a lot of what we tend to learn in school is a bit outdated and based on models from like Descartes and stuff like that from like 400 years ago.
Hmm.
Depending on the school you go to, because some of them are going to be more updated. Um, and have like a misrepresentation of what our current understanding of pain is. Like if you were to look in literature from the last 10 years.
Hmm.
So now there's a lot more where it's becoming something that you have to learn as you like either in school by your own like researching or once you get done by doing additional coursework or reading into literature.
Yeah, yeah. So that's kind of, I mean, I guess most professional industries, like most doctors of nature, have that kind of like basic knowledge. But I was teaching a course or a lecture on sports nutrition a couple weeks ago, and like I was looking through the textbook that we kind of recommend, and I was like, wow, this stuff it's a fairly new textbook, but it's already 5 to 7 years out of date just because it takes that long to write and kind of edit and publish a textbook. So I don't think a lot of students realize that, but that's one of the reasons that we can go to the main like literature and say, hey, let's look at this study because we've had a lot since that chapter that I read 5 years ago. So in their kind of tests, they had the uh, LBP test, the leg pain, trunk flexion,
Hmm.
and then a couple of different kind of questionnaires. Did
Yeah.
anything really stick out to you in that, like the results, or maybe why they included them or anything?
So, like, so this researcher in particular is very good about um, utilizing a lot of measures that are going to be usually easily reproducible, have some kind of already established like minimal detectable change or minimal significant change to like a clinical result, um,
Hmm.
and ones that are usually highly validated and widely used. So like um, straight leg raise is one that has a significance measure, and would be used in a lot of people with back pain. Trunk flexion, similarly, and seems to be more related to somebody's functional. And those two measures are selected because they're the ones that show more difference on what somebody's outcome might be. Like as those things get better, you see this tend to see from what they're citing better outcomes.
Yeah. So I'm not as like a so this is obviously not my area of research, but I
Yeah.
do find it quite practical in the sense of what we tested. Now, the fact that they had a lot of people in this intervention, but didn't reach kind of that clinical difference that we often look for.
Yep.
Um, but then I mean, they did statistically find differences, which is usually kind of harder. But do you think that changes anything, or do you think those kind of minimal clinical differences matter in this case specifically? In life they do matter, but maybe in this case. So it's like +4 on the grok, and then there's a couple other kind of 2% increases that you look for.
Yeah, I thought that was interesting because typically, like in a like common patient that you see, you're not gonna just do 15 minutes of like education. So that may be incorporated with exercise, and there's been um, papers already that show that when you incorporate this more with like exercise as well, that it has a bigger effect overall on the um, like the outcome that you get. So if they're already kind of close to some of those clinically significant differences, and all they've done is talk to somebody, then potentially you have the chance of in future study looking at, okay, maybe I take this like start back tool, and then we go, okay, maybe I educate the people that are in low risk, and then add in um, exercise to other people in those groups, and you may hit um, those statistical differences that we want to see, or the detectable changes.
Yeah, and I honestly think with this type of intervention, it's it's not like you're putting the patient at risk, right? This is kind of like um, something that we may do in exercise where it's like, okay, well, we know it's safe. We're not going to put them in danger. We're not going to make things worse by just talking to them.
Yeah,
Um, and so, very kind of on the practical side, if I was a PT, I would say, wow, if I'm not sure this works, I'm going to try it because there's a chance that it works. And these people are at risk, and lower back pain is kind of like pretty serious.
yeah,
So I guess I don't see why I would not use it now. The they did a lot of test retest measures, which I have a little bit of caution with,
mhm,
um, because right, if you test something and you retest it, then you're going to do better
yeah,
the second time. So a control group would have been really nice, even if it was, just talk to them for 10 minutes about their day or something, because I'm sure there was some improvement there.
yeah.
Uh, whether or not it's more, probably a little bit, just because you're talking about something specifically. Um,
Well,
but so, go ahead.
that's where like I wanted to see like because we talked about the pain rating and the flexion and stuff like that. Like um, maybe they should have tested. Like they mentioned, they didn't test some of them again because they didn't expect there to be any change and like the same day.
Hmm.
But then I was curious, like, so what if you did retest it though, and there was like a huge change in somebody's like beliefs about their back pain, which made them then change their answers about something? Because that would be
Yeah, and that would be pretty easy too, because I mean, if you don't know something exist essentially, then how can you give an appropriate answer um, just from a questionnaire standpoint? So that's, I mean, that's a really good point. So I guess that's something that you would have liked to see. And is there anything else that really like you're like, oh, I wish they would have done this, or that's a strength or that's a weakness, anything like that that sticks out?
Um, I had a few written down here. Um, because it seemed like we talked about it was more like an exploratory test. Um, when I scored it using like a Pedro scale, I tried to use the Oxford scale, but they didn't have one that was more for a single arm trial. It did score pretty well overall. Um, and then really it was more of like it seems like more of a study that's for future application and like you said feasibility than it was like we didn't we kind of got some uh like pieces of the puzzle but not like an actual answer. So this ended up turning out to be like how most research is. It kind of gives you like hints at future research but no real answers right now.
Yeah, yeah, and that's pretty common. I always tell people who say stuff like that, like detrimentally. I know you're saying it optimistically, but is that you gotta start somewhere, and you can only do so much in a single study.
Hmm.
Um, so that's really important to remember because every time we add a test or add in my case, maybe a biopsy or a blood draw or something like that, we add burden to the patient or the participant, and we can only ask so much of them before they're like, I don't think so. I don't want to do this. Or you get halfway through it and you're like, no, I think I'm going to quit now, in which case you get no data. Um, so I think the next steps for me when I read this, I was like, okay, well, I would love to see another group just for comparison. Maybe throw in some exercise, like you said. That would be a nice, maybe a more chronic study where it's, let's say, two to 4 weeks or something, and just have them come in once a week and do some kind of exercises and education. Um, but I mean, I other than that, would I don't really see that much wrong with the study in general.
Yeah, and I think most of the scoring that I found flaws with was like um, that they didn't have more than one group to be randomized, and you couldn't really like I don't know if you could really blind like somebody with the from a intervention standpoint. Like I can't like educate somebody about pain and not know that I'm doing it.
Yeah, yeah, I guess the best you could do in that scenario is have blind assessors
Yeah,
so that they don't know. But in a clinic, the person assessing is probably the person educating. So,
or even if
there's
go ahead.
yeah, there's some things you could do, but you're right. There's a limitation. Kind of like if I'm exercising, well, I know I'm exercising. I can't be blinded to the treatment, right?
You could be
So,
blinded to like what treatment group you're in, or you could blind like the assessor or the person giving the intervention as to like which group that person's in. This person's in
yeah.
education and uh, exercise group, um, or even if it's somebody that's like in those different stratified groups of like low risk, medium risk, high risk, or even somebody that doesn't have pain.
hmm Yeah, and I mean, segregating out into the low, medium, high is probably really important too, because if someone's at high risk and your intervention works at all, like you're like, okay, well, I'm doing it because they're at high risk. Um,
Yeah, and that's
so
so important because the start back originally was designed so like primary care physicians could give it to somebody very quickly, and then it would help to determine maybe like which pathway of care that they're giving them. And even like for myself, I can see patients direct access where they haven't seen anybody yet, and that's going to clue you into like, okay, I need to make their physician aware of this, or no, this is somebody like I can see just a few visits, make sure I teach them a few things, and get them on their way.
Yeah, yeah, I definitely agree with that. Okay, so that's pretty much the basics and some good context, I think, for people who are listening or watching. Because a lot of times you can read a study, you can be like, oh, I understand what they did, but I may not be a PT or may not have that background. So I think that's our main goal is to do that, and then talk a little bit about design, rationale, and feasibility. So, did you have any last words or anything else you wanted to add before we wrap up?
Um, More of it, I would say, like if people really wanted to, I mean, if people want to know more about this, like I post a lot of these types of things on my Instagram, but also the group of authors here, especially the main author, Adrian Lowe, they have very good papers on this, and some of them aren't just like studies, but they have um, kind of like they have one like that clinical application paper where it like talks through like this is kind of like how you would go through a session and incorporate this into your day-to-day practice and things like that. So there's a lot of
Nice.
made to make this easy for somebody to take in like in practice versus just some arbitrary things that you have to really extrapolate and work hard at to make apply to your patient population.
Yeah, yeah, no, that's really good to know too. And I'll put links to your stuff and kind of the comments when I post the video after I edit it and get it all cleaned up. Um, okay, well, I don't think I have anything to add, and I know that you have a baby trying to get to sleep. So thanks for chatting with me, and hopefully we'll get some different kinds of studies in here. I think this is a good like branching out of, it's not hypertrophy based. I think our next one might be nutrition based or something. We haven't done one of those yet. So,
Yeah,
it,
I'd be interested to get another one in eventually in the future about neuroscience changes and physiology markers too, because I've got a few of those in my my red stack in the clinic.
yeah, yeah. Okay, so I will. I'll cut the recording right. Um, Yeah, no, that was good. I think that should give people some really good context. My goal is not necessarily to sit here and tell people what the study was about, but
Mm.
give